lowest rates in the county. This is the heat map that shows the last 30 days. The previous map was it really gives us a better idea of what's going on right now when we look at what are we seeing in the last 30 days. And so this is a heat map from the last 30 days. And you can see that, you know, we had a time where we had a lot of pale pink all over the place. We are getting some significant yellow hot spots again. You don't really see any of those tight circles, which look like apartment complexes, but you do see some significant areas where there are definitely lots of cases. And some of these areas are similar to what we saw back in, say, May through August of 2020, when we had a lot of cases in 48911. By sex, the cases are 53% female and 47% male. And then by age, again, just for the last 30 days. So I think in the last media briefing, we were showing you the cumulative and the last 30 days. Really is, again, a better capture of what's going on right now, which is really what we want to know about, in addition to the cumulative statistics, which are always going to be there. In terms of these numbers. So 20 to 29 is our highest percent age group, has been for quite a while. That 30 to 39 age group is significant, and you'll see in a minute that that's actually our highest rate in terms of age groups, with the 10 to 19 as well as the 40 to 49 at 13%, 0 to 9 at 9%, and that very different from last year. And we're at 1% for our 80 and over. So if you calculate those by age-specific case rates, in other words, what's the total population of people 80 and over relative to the number of cases, and calculate that per 100,000, then it's pretty easy to see that percents show you one thing, but rates show you a completely different thing. So the 30 to 39 age group is our highest rate age group, followed by the 40 to 49, and the 50 to 59. And then we drop off from there to the 20 to 29, 10 to 19, and then 0 to 9. So really our age groups that are lowest at this point in time in terms of rate, as well as percent they're low, are basically 60 and above. So the 60 to 69, 70 to 79, and 80 and over. If we look at cases by race, 61% Caucasian and 13% Black or African American, 3% Asian, and 10% unknown, 13% other. I've explained that many times. A lot of that is our Hispanic population. So if we look at that by rate, the Asian population rate is actually lower than Caucasian. We tend to base off Caucasian to see where our disproportionate burden is, because it usually is a you know, related to people of color and disproportionate burdens of illness and things like that due to really social determinants of health, nothing genetic or anything like that. So that's about a 44% difference between the Caucasian rate and the African American rate. So it's 44% higher. If we look at our Hispanic and Latino population for this year, 72% not Hispanic or Latino, 8% Hispanic or Latino, 19% unknown. And that's probably going to turn out to be significant when we have the time, as we did in July, to basically go back through and get a lot of race data that sometimes is missing when you are basically trying to call, you know, 2,000 people or figure out all of the demographics for 2,000 people in a week or 1,400 people in a week. That's a lot of cases to deal with in a week. And so filling out an entire survey form, sometimes you're missing race data and things like that. So we try to fill those in after the fact, race and ethnicity, excuse me. So the Hispanic or Latino population has a 33% higher rate of cases, so slightly lower than the difference between the African American population. But this gets very different when we look at deaths, so we're going to get to that in just a minute. Deaths by zip code, 48911 and 48910 in 2021 have been leading the way. As you'll recall, last year it was 48823, and 48823, a lot of that had to do with a significant population and a significant number of long-term care facilities that are in that particular zip code. And last year we were seeing that 65 and older deaths and a lot of deaths in long-term care facilities as well. Now we're looking, with the vaccination rates higher, with long-term care facilities, largely vaccinated residents, what we're seeing is more what's going on in our community across the board. And 48911 and 48910 are the two highest, with 48912, 48906, and 48842 kind of at about half, a little more than half those numbers. When we look at deaths by month, so this is where I told you we're probably going to finish out December of 2021 with probably our second highest number of deaths in a month. December of 2020 was the highest. I don't think we're going to reach the 83. We do only have a few more days, and then they do the vital record search, and everything is always lagging behind. So we are at 56. I do expect there to be more than the 58 we saw in January of 21 by the time we finish up December of 21 data. So definitely improvement over December of 2020, but still a significant number of deaths that have happened in this climb that we've been seeing. I mean, and you can see this slow, steady climb even in the deaths, which before, last year they just kind of jumped up and then back down. It was a sharper curve up. So we have had a very slow curve up since July. When we look at deaths by age in terms of percent, it is, again, vaccination impact really shows when we look at these things, because we have basically our over 80 age group, which 42.7% of our deaths in 2020 were in that age group, whereas we're down to 28% now. And you see that difference here as well. And then when you get into these other age groups, you see the opposite, and you see the deaths increase in 2021 compared to 2020 in those age groups. And at the same time, we also see declining vaccination rates in these age groups compared to the 65 and older age groups. So we have a flip-flop in the statistics when we look at deaths by sex, where it's actually more men or male than female. So 53.9% of our deaths male, 46.1% female. And by race, you can also see that, and as I explained that I would get to in a minute with the ethnicity and race stuff, is that the Caucasian deaths by race dropped, but also the African American deaths by race dropped a little bit. And other is up. And again, that's oftentimes where we see some of our Hispanic population just not showing up in our race data because of the way race data is collected in this. When we look at our Hispanic or Latino population versus our non-Hispanic or Latino population, we can see that. We can see that the 5.6% last year compared to 11.6% this year in our Hispanic and Latino population in terms of deaths. That's pretty significant. When we look at the African American versus Caucasian deaths, race-specific death rates, so per 100,000 population, and again, keep in mind scale here, so this is on a scale of 85 to 115, that is actually just a 15% difference between Caucasians and African Americans. So remember, cases 44% higher in African Americans, deaths 15% higher. But when we look at our Hispanic or Latino population, we see the opposite going on. So this is actually a 61% increase over our non-Hispanic or Latino population. So 61% higher in deaths, but 33% higher in cases. So we are definitely seeing some pretty significant impact on our Hispanic and Latino population at this point in time. When we look at vaccination rates, our vaccination numbers, we are still at 96.6%. Like I said, you can see that in a lot of our data in terms of cases and deaths and things like that, that are 65 and older are vaccinated, and a lot of numbers shifted between 2020 and 2021 as a result of that. But you get down into these lower age groups, 40 to 64, 76.2, 25 to 39, 66.8. Those numbers start dropping off. And then our 16 to 17 age group at 55%, 12 to 15, really we're doing quite well in our 12 to 15 and 5 to 11 age group. I looked at numbers across the state yesterday, and both of those numbers are top 7 in the state. So there are only 7 counties in the state that are at 30% or higher with the 5 to 11 age group, or at least yesterday that was the case. And there are only 7 counties in the state that are at 57% or higher in the 12 to 15 age range. So we currently, for our age 16 and up, which was kind of our, our benchmark that we had been following when the vaccine was first released, because it was not available under the age of 16 at that time. So we set our bar based on who was eligible for vaccine, and we were trying to get to 70%. Well, we're at 75.3% have received at least their first dose in the 16 and up age group. And then when you add in the 5 to 11 and 12 to 15, we get to 70.9% of all eligible Ingham County residents who've had at least their first dose of vaccine. Then just a few things from the state's data and modeling update, because it's kind of nice to bring those in sometimes. Obviously, talking about Omicron, we still are really learning things about Omicron and building the data around that. So it is likely we are seeing that Omicron is more transmissible, more highly transmissible. And that's one of our concerns over the month of January is just really just sheer numbers of cases. Because when it comes to severity of illness, we do need more data, but it's certainly looking like it's not more severe and could potentially be less severe. Will the vaccines work? The current vaccines work, especially with the boosters. So we are really emphasizing how important it is to get the booster. I would not be surprised if sometime in the near future, the CDC changed the definition of fully vaccinated to the 2 doses plus the booster, as they just did with the new quarantine guidance. So you saw that distinction in the quarantine guidance. I would not be surprised if we see that distinction as well elsewhere. So vaccines work against illness in general. I think we're seeing about 70% or so efficacy, 75% efficacy against Omicron. But in particular, again, getting mild illness is very different than thinking about whether that vaccine is protecting you from severe illness, hospitalization, and death. And that is where we need to really focus on our vaccines and the efficacy of these vaccines, is that they are indeed, even beyond the 70%, protecting against severe illness, hospitalizations, and deaths. Treatments against Omicron, we're still working on some more data than that. Treatments by monoclonal antibodies, some of the antivirals and things like that. We are hearing that some of the monoclonal antibodies might not work as well as the others. And so they're working on supply chain issues with the monoclonal antibody that they think is actually going to be more effective with Omicron. We do have tools to fight Omicron, vaccines, especially the booster, continuing masking, avoiding large indoor crowded settings, and of course testing. Testing is very important. And you heard the president probably yesterday or the day before talk about testing and the fact that, we've just got to admit that we did not do a very good job in the United States on testing. And we'll talk a little bit more about that towards the end too. And then always multiple levels of mitigation are more effective at preventing transmission. So remember that Swiss cheese diagram with holes in the cheese, and the holes are in different places, and they create barriers when you layer them together because the holes aren't aligned anymore. So this is, again, an interesting comparison of what happened last year. So this was our first wave in April of 2020. And here's what we saw in March, April of 2021. Now, keep in mind, we didn't talk about inadequate testing back in April of 2020. We really still were not up to full speed with testing, even as it is today. And then we have our holiday wave here. This is last year's. And as you can see, except for the slow, steady increase that came through here, we did kind of just, jump on with the same pattern that we saw last year. And it would not surprise me if this becomes sort of in here and into, maybe February, March, kind of COVID season, just like it's flu season. You know, you're looking at October to April is generally flu season. So respiratory viruses tend to be predominant at that point in time. And this is what's happening statewide. So you can see statewide even, we were coming down a little bit, had a bump up. And yeah, that bump up does align with shortly after Thanksgiving, but it's on its way back down again now. So it was a slight increase and looks like it could be related to holidays and holiday travel. So if we look at cases and deaths by vaccination status, so you can see that cases, we've had a steady increase in the number of cases in vaccinated individuals, but nothing compared to what we see in unvaccinated individuals. So a 4.3 times risk of testing positive, 4.3-fold increase risk of testing positive for COVID. And as people get those boosters, I mean, you're here, you know, in October, you're starting to get to that point in time where you are getting more than 6 months out, but not yet. We didn't approve a booster for all populations until sometime in September. So you're getting further and further out from that 6-month window, especially for our 65 and older population, who many of which got vaccinated between January and March. And then we opened up eligibility to our other age group towards the end of March. But now we're getting to the point where that age group and those age groups are now needing boosters or eligible for boosters. If we look at the vaccination status and COVID deaths, you can see, you know, an even more remarkable difference in terms of, you know, unvaccinated and deaths, and you don't even really see this gradual steady climb. And we had a little bump up, but this is really staying fairly flat. And this is our concern with Omicron, is that vaccination is protecting us from deaths, but when we have sheer numbers of cases go up, we have increases in deaths in both unvaccinated and somewhat of an increase in fully vaccinated. You have a 13.2 times increase of a risk of dying from COVID-19 if you're unvaccinated. And so obviously the vaccine is clearly working in the ways that we had hoped that it would work. I think, had hoped that it would be a little bit more effective at preventing illness in general. But again, a vaccine that prevents serious illness, hospitalization, and death versus a very mild illness is a really good vaccine. But that's when it becomes more important to protect the vulnerable around us, because again, there are people who cannot get vaccinated or are so severely immunocompromised that a vaccine even will wane quickly on them. Then I was talking about testing. So just a little bit on testing. Again, as I said, we heard President Biden admit in a meeting with the governors that, you know, we had not done that good a job in the United States with testing. We are seeing testing lines again. You're seeing in the news, you know, people waiting in lines for hours to get tested in Florida, people waiting in line for hours to get tested places. That's happening again at Sparrow. And Sparrow Health System did a phenomenal job of standing up and getting testing going in this community when there was none. And it's kind of been our go-to. It's in our head, the place to go. But you should know that there are other sites, and I don't, this is not an anti-Sparrow or anything, but what I don't want is for people to be waiting in line for hours to get tested when there are other places where they possibly are not waiting in line. So LynxDX is a company out of Ann Arbor, biotech company, testing company out of Ann Arbor. They reached out to us in Ingham County and asked if we'd be interested in them bringing a testing site here. And my answer was, more testing in the community is better. We had to find a location for them. It turned out the location for them ended up being in our parking lot. So it really is right here in our parking lot. There is no out-of-pocket expense. It is a PCR test, but it is a saliva-based PCR test. So especially for these little ones that don't want that nasal, you know, that swab shoved up their nose, this is basically a little tiny tube and you spit into it and they do a PCR off of that. So you will not be turned away if you don't have symptoms, and you should have results within 48 hours. Sometimes it's quicker than that. So I think I had mine in, was less than 24 hours when I tested there. So just wanting people to know that there is a saliva base, so no nasal swab, PCR, testing site right here in, on Jolly and Cedar. And generally, at this point in time, there's no line. So hopefully if we can kind of spread this testing out a little bit, that will keep people from sitting in lines for really long periods of time to get testing, because we're starting to see that trend start up over the country. And the reason for that trend starting up over the country is because we just did not do a very good job of making testing available in the United States, between home tests, testing sites, just across the board. So more testing sites means less waiting and less lines. So it's really important that we know where those testing sites are and what your options are, so that, I mean, everybody doesn't have time to wait 2 or 3 hours to get tested. So just wanted to make sure you were all aware of that. And that is it for me.
Thank you, Linda. We will move into the question portion of today's media briefing. If you have a question, please utilize the raise your hand function and I will call on you to ask. Jake, you can go ahead.
Hi, Miss Linda. How are you?
I'm good, Jake. How are you?
Good. For News 10, we're wondering, so concerning the new CDC guidelines, the 5-day quarantine, what symptoms for at least you guys at the health department, or at least from what you're hearing, what are you guys looking for? What's okay to have after the 5 days? Is it okay for people to have coughing, sore throat, fatigue, things of that nature?
So generally, so what you want to do is, and it's same as it was before, it was 10 days or until you were 24 hours fever-free and symptoms are improving. So when you get COVID, it's like you get sick and then it gets worse and it stays bad. And then suddenly it's like, oh, I'm getting better. So what we want is symptoms improving. The typical symptoms that will last are going to be things like a cough, little residual cough, oftentimes some fatigue, and maybe a little bit of congestion. But things like the sore throat and the muscle aches, the fever, the chills, the rigors, those sorts of things, those are definitely severe, those are symptoms that you should be still in for. So those tend to be the ones that are kind of linger for a while, just like any cough. You'll have a cough for quite a while after you're really sick with the cough. And that is the case with COVID as well. I probably didn't tell all of you at the time because I didn't want to do media interviews about it, but I had COVID in October. And, that was pretty much the case for me. I was sick for a few days as a vaccinated person. It wasn't very severe at all. And eventually that tight, dry cough dropped a little bit, and I had a little bit of a cough for 2 or 3 weeks after that. But I certainly was not sick beyond probably, as a vaccinated person, 2 or 3 days, because as we look at these isolation and quarantine guidance changes, my preference would have been that we would have made some sort of distinction between vaccinated and unvaccinated, and not really as a consequence sort of issue. What we know when you're vaccinated is that helps your body clear the virus faster. So you truly are contagious for a shorter period of time.
I think that leads into my next question I have for you. So what about for people who may be unvaccinated or in the contagious part? How long are you really contagious for? Because it seems as though you would think that if you are still experiencing symptoms, cough, fever, fatigue, sore throat, etc., that you would think that you're still contagious, and many people around you might still think you're contagious. What would you say to that and to those people who might think that?
I would say that you don't meet the criteria for discontinuing isolation because you are not asymptomatic or symptom improving. So we want to get to day 5 and have no symptoms, or be fever-free for 24 hours and know that your symptoms are improving. So if you still have a fever, if you're still coughing bad, if you're short of breath, if you're fatigued, your symptoms are not improving, and that is not the end of your isolation, and you are still contagious. So that's my best advice, is that pay attention to that part about it that says that you're supposed to be symptom-free or have considerable symptom improvement before you really are safe to discontinue isolation.
So it's not necessarily a something to be married to. It's just a suggestion in your own words. Is that correct?
No, that is what you should do. That's not
right. I mean
Yeah,
I mean the 5 days is what is the 5 day quarantine for
the
right
5
now.
days is a minimum, and that's,
Okay.
you're talking isolation right now, not quarantine. So
Okay.
isolation is for the sick. They're both 5 days. They were both 10 days. So if you're sick, you isolate for 5 days, wait for symptoms to resolve. If symptoms haven't resolved, then you've got to continue isolating. The quarantine is for people who are exposed. So you're a close contact to somebody who had COVID. That now is also 5 days with the additional 5 days, because it used to be 10 days, of basically asking you to wear a mask. And if you do end up getting symptomatic, then you should stay home.
Awesome. One more question, Linda. I know I'm
Okay.
taking up a lot of your time right now. Are regular cloth masks okay to wear, or would you recommend the N95 masks? There are reports coming out saying that cloth masks aren't necessarily as effective with the Omicron variant, potentially being a little bit more transmissible and highly spreadable compared to Delta. What would you say to that?
That is accurate. And even cloth masks come in different qualities. So if you're going to wear a cloth mask, it's going to be preferable now that you make sure that it's a multi-layered cloth mask and a closely fitting one. Like this one, has that, shape where it really closely fits to your face. It's a cloth mask, and it's also about 3 layers. So the N95 mask or the KN95 mask or the KF94, I think is the other one, are your most effective masks. The surgical masks are the next, and then your cloth mask is after that. A cloth mask, again, look for the multi-layered ones, things like that, the good fitting ones. A cloth mask is still going to be better than no mask. And keep in mind with the N95s in particular, not the KN95s and not the KF94. Is it KF, Madison? It's the Korean ones. The KNs are Chinese and the other ones are Korean, and the other one's 94. I think it's KF. Those would be the ones that you should turn to, because the N95 masks are what we need for our healthcare personnel in the hospitals, in clinics, because as we talk about surgical masks or cloth masks not being as effective, what we need to remember is that in every medical practice in this county, as well as in our health systems, we now have healthcare workers who probably should be wearing these more effective, more protective masks, because they are working with sick people all the time. So we still want to preserve that N95 for our healthcare workers, and definitely go towards those KN95s, KF94s, those kinds of masks. Like I said, that's solid advice. But what I would say in addition to that is that a cloth mask is still better than no mask. But do look for the ones that are multi-layered and close fitting.
Linda, thank you for answering my questions.
Mm-hmm.
Thank you, Linda. And yes, you're correct. It is KF94. Sarah, you can go ahead and ask your question.
I was wondering if there's concern about underreporting because of people doing at-home tests, and are people given good enough instructions about how to report a positive test result that they're doing at home?
So there is no requirement. I mean, we'd like for home tests to be reported, but that was part of the problem when home tests went out. But keep in mind, Sarah, that underreporting is something that's gone on for a long time. There are plenty of people that are either asymptomatic and we never knew, or simply, got sick and stayed home and, didn't go get tested. We even advised that at the very beginning when testing capacity was not as high as it is now, was that, if you've got everything that seems as if it's COVID, there's no reason to go to the doctor's office and get tested. Just stay home because you're sick. So yeah, there is some underreporting. But, I'd rather people be doing home tests and us not know every single one of those results, because there's also underreporting of negative results, which would change your percent positivity. But at least people are testing, and they have options to, test before going to a family gathering, test before travel, test before, going to some other sort of social gathering. We got New Year's Eve coming up. So there are lots of things that when you talk about the benefits versus the drawbacks of them, that there are so many things about the home test that really are beneficial to us in general that it just doesn't concern me.
If someone does take a home test that's positive, do you have advice for them on if they want to report it? What should they do? Should their first step be their doctor, who then reports it to the health department?
Some of the home tests have actually a telehealth component connected to them, and then they do get reported. So if you buy the tests that basically end up with the telehealth thing, then they can be reported, and you can always do that. They'll walk you through and make sure you do it correctly. So some of them are tied to that. The other ones, basically, you could call your doctor's office and say, I have a home test and it's positive, but quite honestly, laboratory confirming of cases needs to be actually confirmed. And since nobody actually witnessed the test, nobody saw the test, you're just kind of anecdotally reporting it, it's really not something that would end up being counted unless it's done in that interaction via telehealth. And they've looked at the home test too and looked at other ways to do it, like with QR codes and things like that. So that's just yet another thing that we need to work on in the United States with regard to the home tests is, what happens with that? And at some point in time, just like with flu, we probably will quit testing and counting every single case. When you think about flu, and I talked to Tony about this morning, we do flu surveillance. Everybody that gets the flu doesn't get tested. So flu surveillance works like this. There are providers in the community that serve as sentinels. And what they do is they report the number of people who come in and have influenza-like illness. So you'll see it as ILI, influenza-like illness, because it wasn't necessarily confirmed by a laboratory test. Then what they do is they send a sample of those in to be tested, and that gives you the general overall trend. So they agree to report influenza-like illnesses. They agree to test a sampling of the people who come in with influenza-like illness, and that allows us to see when flu season is starting to peak, when flu season is ending. It allows you also to see some things like how effective is this year's, the vaccine, those sorts of things. So, we do have flu seasons. We've had flu seasons in the 15 years I've been a health officer that peaked in December, which is odd because it usually peaks in February or so. So at some point in time, I think we're going to get there. And so the urgency of needing home tests to be reported is probably going to kind of fade out as we move into 2022.
Dustin, you can go ahead. Dustin, do you have a question?
Oh, sorry about that. I was muted. This is Dustin Dwyer from Michigan Radio. My question is along the same lines about testing capacity in the county. If there's a spike similar to what New York or Florida is seeing, will there be enough tests to go around? And do you have concerns if there aren't?
Well, that's one of the reasons why we're trying to make sure people know that there are more testing sites, because what's happening right now is, and like I said, this is not an anti-sparrow commentary at all. It is just a commentary of we're seeing that line grow. We're seeing lines grow in Florida. As Omicron hits, you can expect that line to get longer. And so when everybody in this community is going to a single testing site, that's what's going to happen. If everybody in this community started to be aware of the fact that there are other options, there's a neighborhood testing site on Jolly that the state runs. There's this testing site here. They do testing in urgent cares. Of course, that could land you in a wait as well. So drive-through testing like Sparrow or this, it's kind of hard to tell because we still haven't seen this site that we opened up here, I think over the summer. We haven't seen it utilized as well as it should be. We're still really trying to work to get the word out and hoping that you'll help us. Because again, we don't want to see people waiting in lines for as long as they are. And we do want to make sure that we have enough capacity in the community. And it's really hard to tell when everybody's tending to go to one site and then backs up. And then you've got a site somewhere else where, part of the day they are seeing no one. And that's what's happening right now. So I can't give you a really great answer to that, other than if we start to get people, to distribute the testing need more evenly through the community where the testing places are, then we'll get a better sense of how well we're meeting that demand.
Thank you, Linda. Do we have any further questions for Health Officer Vale? I'm not seeing any further questions. So our next media briefing will be Tuesday, January 11th. In the meantime, please feel free to reach out with any questions. Thank you for joining us this afternoon, and I hope you all have a great start to your new year.